Then went to the Detroit Gun and Knife Club and was at St. John Hospital there for residency. And then did a mini fellowship in trauma at University Hospital Vienna, Austria. And then went into private practice in Detroit, actually a suburb of Detroit, for 8 years. And had our first child in 2005 and decided we needed to move a little closer to home. So I made a move here in 2006 and it's been the best move we could have ever made. It's a great place to raise a family, obviously. You guys probably all know that. Anyway, today we're going to talk about ankle replacement. In those years, in just the years that I've been here, from 2006 to now, ankle surgery for arthritic conditions has changed dramatically. From primarily fusing most ankle joints to primarily replacing most ankle joints, really in the past 6 years, is a pretty big transformation. I see a lot of ankle problems, a lot of ankle injuries, subsequently a lot of ankle arthritis. And we're going to talk a little bit about the different types of arthritis and kind of how ankle replacements changed over the years. So we'll talk a little bit about arthritis and who it affects. We'll talk a little bit about anatomy, and then we'll talk about treatment. So just generally, arth means joint and itis, inflammation, so inflammation of a joint. Lots of types of arthritis, probably much more than is on this list, but the most common ones are those three at the top there. Osteoarthritis, your typical wear and tear arthritis, rheumatoid arthritis, and post-traumatic arthritis. And post-traumatic arthritis is probably where I think ankle replacement has made big changes in the past 6 years. And we'll talk a little bit about that. So what is osteoarthritis? So in general, you're talking about all joints. It's a degenerative joint disease is another name for it. It's the most common form of arthritis. Affects a whole heck of a lot of people at 27 million. And they think that's going to double, more than double by 2030. It's basically a wear and tear condition that develops over time. Can affect people of all different ages, but osteoarthritis is going to be more common in an older patient population typically. But it can be associated with an injury, it can be associated with overuse problems. It can be related to a developmental problem. They could have been born with a certain foot deformity and develop arthritis in other joints. It's just like knee arthritis can oftentimes come from a foot condition. So it's all kind of related. So basically your typical symptoms of arthritis starts as warm to the touch, the joint is swollen, there's pain, immobility, it starts to stiffen up. And those things are probably when you're kind of treating the conditions yourself at home. Anti-inflammatory medications, maybe some physical therapy techniques. But when you get to these bottom things, decreased activity impairs your lifestyle, and you start to get deformities in the joint, you're probably going to search out, some opinion from someone like our clinic. When we talk about deformity, that becomes pretty important. This X-ray on this side here shows a pretty straight joint that's very arthritic. There's no space, and we'll look at some more X-rays so you get an idea of that. When you look at this side, there's quite a bit of deformity. This bone's called the Tailless. It's actually tilted quite a bit, probably 20 degrees. And I think personally, over 6 years of doing ankle replacement surgery here with the newer implants, I think for me this has been a big area that did not get an implant before. These people were almost always fused because you couldn't correct enough of the deformity with the implants that we had. So I think this is kind of an important part of the newer technology. Demographics, this is all arthritis, so our big list of arthritic conditions. So it affects 70 million people, lots of different types. It affects all ages, usually worse after 45. That's probably because osteoarthritis tends to be worse later in life. More women than men. I don't know if I have an answer for that. Women do tend to seek medical attention quicker than men do. That may be one thing. Demographics really across the board pretty equal. A little bit on anatomy. We won't get into this too much, but this big bone, your shin bone, is called the tibia. So that knob on the inside of your ankle is here. It's called the medial malleolus. This bone, long bone, is called the fibula. That knob on the outside of your ankle is the lateral malleolus. And then this bone is called the talus. This is probably the most important bone when we talk about implants and how they've changed over years. The talus is an interesting bone. It's very dense bone with very poor blood supply to it. It's nearly completely covered in cartilage. It, like one of the bones in your inner ear, has no tendon attachment. So it's one of the only bones that does not have a tendon attachment to it. But it's this bone and its complexity with the joint below it. There's a joint here below it called the subtalar joint. And that's, I think, where some of the difficulty in ankle replacement has been, trying to develop the right implant for the ankle joint itself. And there's a ton of stress on this joint if you think about body weight and how small this joint is to take up all that body weight. It's a little different than a knee or a hip, where maybe the weight is diffused a little bit more. So osteoarthritis, if we're going to look at the normal or close to normal ankle, you'll see kind of a nice black space here. That's actually cartilage, so it's not a space. You look at a pretty arthritic ankle and you don't see that space. So different degrees of arthritis is basically based on how much space they have left and how much deformity they've developed. And you can look at early stage, middle stage. You probably won't see early stage because that's where you just have the joint warmth. In an early stage, you'll get a thickening of the capsule, the inner lining of the joint capsule, and it will start to form these finger-like projections, which causes the stiffness across the joint. And we'll talk about some of the treatments and why that would help that particular problem. Late stage, again, if you look at no space here, this is a front-on view, and this is a side view. Basically, this one like that. So some of the treatments, you guys probably know a lot of these, especially if you have any arthritic problems. Non-steroidal anti-inflammatory medications, so ibuprofen, Advil, Motrin, which are all the same product, and Aleve are common ones, and then those are over-the-counter, and then there are prescription medications like Celebrex and Mobic and some other ones that are non-steroid based. Corticosteroids can be either pill form or injected form. The injected form can either be IM, which would be treats your whole body or systemically, or it can be intra-articular, so if you've had a cortisone injection, that's what you've had. Physical therapy can be helpful in strengthening tendons around the joint, increasing mobility, treating the inflammation. And then bracing can be helpful, and basically a brace is just locking up the joint so it doesn't move. A joint is only painful if it's really arthritic and it moves. If the joint doesn't move, it's not going to be painful. That's why your body's always trying to heal itself, so that joint will become stiffer, stiffer, stiffer. The body will build up bone to try and lock that joint up, and if it is able to do it, your pain might go away. But to get to that point can take years and years and years. So some surgical treatments, we talked a little bit about the soft tissue thickening inside a joint on the early stages of arthritis. So arthroscopic debridement of the joint can sometimes be helpful in the early stages, but it surely probably isn't going to take care of the problem long term. So then you start talking about basically the two main surgical treatments, arthrodesis, which is fusing the joint, or replacement. So fusing the joint was the mainstay for a severely arthritic ankle for years and years and years. It was the gold standard. There were basically two generations of implants. The earlier generation did not really pan out. The implants either didn't last or they changed position and they didn't work. And so ended up taking patients that had implants that failed to fusing, and that's pretty difficult to do at that time. So a lot of those patients unfortunately ended up with amputation because prosthetics are so good that it was easier to go right to a prosthetic than to try and revise this fusion. So with the advent of, with the changes in replacements, the implants themselves, it's transformed a huge amount. And we're going to talk about some of the different types here shortly, so I'll get into that a little bit later. So what is total ankle replacement? Basically, you're taking away the arthritic joint. The ends of bones are capped, usually with a titanium and or cobalt chrome piece, and then there's a polyethylene or plastic spacer between those two pieces of metal. Same technology as hips and knees, basically. What's the benefit from maintaining motion is a huge part of why replacement is better than fusing. If you think about why a joint moves for a reason that dissipates energy. And so if you fuse a joint, other joints adjacent to that joint are going to have to take up that energy. So other joints adjacent to the fused area are going to become worn down over time, so they become more arthritic. So by maintaining motion in the ankle joint, you actually can decrease the amount of problems proximal and distal away from that area. And it's supposed to be more natural, more naturally replicates your feeling and how you feel during gait. It's quite an old slide now. So since 2011, in 2011, 4,000 implants were performed, probably primarily in bone. I don't know if you know those numbers up to date, but probably not. It's really become quite a number, actually. So before the newer implants, we had older implants. The first generation really were cemented in place, kind of like knees and hips, mostly hips and knees are cemented in place. So that's going to be the big difference when we talk about the postoperative course. A knee that's cemented in place is ready to be ambulated on almost immediately. That's why patients are able to ambulate or walk within day 1, day 2, day 3 of surgery. For ankle replacements, we don't cement them in place. They're actually coated with a bone ingrowth system. Some hips are press fit like that too. And so the bone has to grow into the device. Well, that's like having a fractured bone. It takes about 6 weeks for bone to grow into the device. So for an ankle, we want you off of it for 6 weeks. So those are two very different postoperative courses. Just a couple of the older devices. This is called a buccal Pappas. Had a great idea. This is a stem that's stuck up into that tibia bone that we talked about. We're going to see more of this. The problem is this stem was one piece, and you couldn't, through the small ankle joint, you couldn't possibly insert this piece in there. So it was very difficult to get inserted, and most times you had to cut away part of the bone to get this piece in there, and it just destabilized the device. So this really never took off that well. This is the agility implant. This is really the implant we had, and I used in Detroit some and a couple of times here. The implant has been around for a long time. It was developed by Dr. Alvine in Sioux Falls, so you may know people that have maybe gone through this. The implant was okay, but it was really designed for very sedentary, older patients. So you couldn't really put it in a lot of people. And it was pretty important that during that surgery, we actually had to fuse the outside bone to the tibia to the fibula. You had to get a bony fusion in here, and if you didn't, this implant oftentimes failed because it didn't have the stability. We call this transverse fixation, so side-to-side fixation, whereas if you had a nice long stem coming up into this bone, that's more vertical fixation. That's kind of how the knee technology is developed. So I don't even know if too many people putting in agility implants anymore because the newer implants are so much better. This is one called the Star. It's actually one of the newer devices. It's called a mobile bearing. This piece of plastic actually floats inside the ankle. There are some people out on the West Coast still using Star a fair amount. The problem with the Star also, it doesn't have that vertical fixation. There's just these two little areas and this one down here that are kind of helping fix it in place. This is called the Salto. This is probably one of the next better implants. We'll talk a little bit about how they're inserted. But the Salto's been, well, it's based here in Minneapolis, so it's kind of common in the Midwest, but really, it does have a little bit of a stem coming up. Where the implants differ in the newer implants, and the reason I use InBone primarily, which is a Wright Medical product, is the way it's inserted. The guide system for it is based on the inner lining of your bone. So the intermedullary canal is how it's guided. That's how knees are done. And it just makes sense to me. These are based off of external landmarks that you have to kind of just pinpoint yourself. So there's more room for error, I guess, in implanting this implant versus the Wright Medical InBone. This is the in-bone. This is actually an old picture of it, but basically it has a stem, but the stem is made of different components. And we can change the shape and size of these components. We can change the length of the components to fit your anatomy. So enhanced vertical fixation, we talked about the length of the stem. We can change what that looks like and how it fits inside of your bone. We can change the shape of this plastic spacer. This is what wears over time. And this is what we're going to watch over time and see how good these implants are. I have patients that are 6 years out from this implant, and I see them back at 5 years, and they're, knock on wood, doing very well without any real appreciable wear of this plastic insert. So we'll just have to see over time how long that lasts. Obviously, in knees and hips, it's the same thing. This plastic spacer does wear.
Yeah, the actual mouse. This one? Yeah, use the mouse that's on the by the laptop there and click on the screen.
You see an arrow?
There you go.
Oh, there it goes. Do you have to?
Yeah, there you go.
This is just a video of the implant going. It's kind of an animated video. I didn't bring the cadaver one for you because it was lunchtime. So this is the in-bone too. In-bone has changed a little bit over the years too, and I can show you where. But basically, incisions on front of the ankle. This is only a couple minutes long. This is called a foot holder. So actually place the foot in this holder. The main thing about this is aligning, because we have to drill a hole through the bottom of the foot up into that tibia bone. So we need to align it appropriately with x-ray. That's what those was doing in the last step. So we drill a hole through the bottom of the foot up into that tibia bone.
It looks painful to watch this way.
And then we place called a cutting block, this piece over the front. That's kind of where we do the sizing. And then we basically cut out the portions of the arthritic joint to prepare for the joint placement, or the component placement.
Like you're framing a house or something. Yeah.
And it's a similar thing with knees and hips.
It's always the part you don't want to see.
Now this is a reamer to make a hole for that stem to be built into.
Oh my gosh.
This is sizing the implant to make sure it's the appropriate length and width for that joint. This is building that stem now. So you can build it however many components you think you need and which sizes.
How long does the surgery take?
Surgery?
Mm-hmm.
How long does it take?
Yeah.
Under 2 hours, hour 20.
Okay.
Depends if we have to do other stuff with it, but not too bad.
Is it robotic going on?
Nope.
You,
Do
okay.
all through this foot holder. That's just putting, this is a tailless piece, that's that cobalt chrome piece, and getting it into the right place and then pinning it. And then we drill holes or ream for there's 3 stems that stick down into the tailless bone.
Basically, you're showing a picture how they're doing the same thing with the knees or hips.
It's very similar. Get that in place.
Get that in place, yes.
Now they're going to put in the poly or the plastic insert.
It's actually more complicated than replacing a knee then, isn't it?
No, I mean, you know, knees just have been around for so long. What?
Looks like the same principle.
It's the same principle, just different pieces.
It's another joint.
So just some examples. So where I talked about earlier, I said the post-traumatic arthritic patients, because they tend to have a little bit more deformity of the joint. I can correct quite a bit of deformity with this joint. I mean, upwards of 20 degrees, sometimes more, with this implant than I could with the agility implant. That's probably one of the main reasons more of them are going in. Because if you actually looked at numbers of patients that have true, just plain osteoarthritis, wear and tear arthritis of the ankle, is not nearly as common as knees and hips. That's why fewer ankles are probably being done, although we're doing 2 or 3 a month now, so the numbers are increasing as I guess the word gets out that it's out there. So post-traumatic arthritis, younger patients, the agility really, I wasn't comfortable in people under 70, 75, sedentary. This implant, I actually have people that are just under 30, which is pretty young. But those people were really up against amputation or try something that's considered new. And one is 5 years out and doing great. So younger patients is a real positive. So a lot of these are actually post-traumatic patients. You can see they've had a previous fracture of their fibula here. This one had a previous fracture. This piece of screw is actually in a really bad spot. It's right in the middle of this bone. So we had to go take that out before we could put the implant in. These are all the first generation. I'd said in-bone, the right medical in-bone has changed a little bit over time. This is actually the original one where it had 1 stem down here. Now the newer one has 3 stems. So it's just a change that's been made, and we found things are getting better with time. We might have to do adjunct procedures with the implant. Your ankle joint might be worn out, but there might be a reason for it. This patient had fallen off a silo, I believe, 20 years ago, and had really bad arthritis in this middle part of his foot, back part of his foot. So at the same time, we fused this joint and this joint, and then replaced his ankle. And he's actually doing very well. This isn't a great example, but another adjunct procedure. This patient really bad flat foot problem, had developed ankle arthritis over time, also had a lot of knee problems. So we took her in, fixed her flat foot, and replaced her ankle at the same time. So the postoperative course, a little bit easier actually than knees and hips. 1 night stay in the hospital. Most people, 98% go home. The other 2% probably go to a nursing home or a swing bed. They're put into a compression splint for 4 or 5 days. That allows for swelling. Then they go into a short leg cast for 2 weeks, non-weight bearing, or what we call toe touch weight bearing. So you can put weight on it when you're stabilizing yourself, but we don't want you walking. Remove sutures or skin staples at 2 weeks, go back into a cast for 4. So the hard part is 6 weeks of not walking, basically. Then I put you into a walking boot for 2 to 4 weeks, and then into an ankle brace, and I tell people, protect your ankle if you're going to be out pheasant hunting or doing something a little bit more active. Put the brace on, it doesn't hurt to kind of protect that ankle. And that's kind of where I'm going to stop, because you might have questions, or if you want to talk about other topics, feel free.
Do you actually get rid of the arthritis?
Yeah, by resecting out those pieces when we showed the cutting block, that's actually taking away the arthritic joint. And it's the same thing in a knee and a hip.
So you would see that in an X-ray?
You see that in an X-ray. If you go back to look at those X-rays where there was no space left, you could see how much that joint was going, I guess.
Maybe we should find a cure for arthritis.
Yeah, that would be the key.
Yeah.
That would be the key.
Alcohol, right?
Now, do you very often just take out bone spurs prior to
Like
doing
out
any
of the
this, or-
joint?
Yeah.
You know, I used to do more of that than I do now, because it doesn't work long term. If someone came in and said, there's a bone spur and it hurts right here, and they're pointing to the bone spur, and that's really the only problem and the rest of the joint looks pretty good, yeah, then maybe it makes sense to do it. It's going to buy them time. It probably is not going to take care of it forever. I'm kind of a believer in if you're going to do something, wait till it's bad enough and then do the definitive thing and not be back time after time. Most people know, and I tell everyone, you can ask anyone that's seen me, you'll be in here telling me to cut off your leg or fix it. Then you know you're to that point of replacing it. But I think there's a lot less morbidity or a lot less complications with implant replacement versus fusing it. Fusing the ankle, and I periodically still have to do it because somebody has too much deformity or there's some other condition going on. There's significant risk with not healing or with it only partially healing. And it's actually a lengthier postoperative course when you fuse an ankle, in my opinion. You're looking at 8 to 12 weeks versus 6 to 8 weeks. So there's quite a few benefits, I think, to ankle replacement. And it seems to be just getting better year after year.
So the fuse replacement line you're talking about fusing together down by the heel?
Yeah, actually, that was a good example. This one. This joint right here.
Mm-hmm.
This patient had another joint that's affected, but this joint is really arthritic. So I actually use these fusion rods usually.
Okay.
It's just another technique.
Are most of the patients accident patients, or are they?
Yeah. I guess I haven't looked, I haven't, I don't know what the magic number is to go start looking at what we've done, but anecdotally, just off the top of my head, I would say probably almost 50-50 with people that have had a traumatic event versus people that don't. And those people that didn't have a traumatic event, they probably have some other underlying deformity, a really bad flat foot. Collapsed arches, you've probably heard of. That's a problem that really can degenerate the ankle and the knee and the hip. So we see a lot of that.
You researching for that too?
Yeah, collapsed arches or flat feet are a little different. If it doesn't affect the ankle, it's different. That's a whole nother topic.